Welcome everyone to COVID-19 Provider Update number 50. I'm Dave Battinelli, Chief Medical Officer, and I'm joined today with a number of guests. We have with us Dr. Bruce Farber, our Chief Public Health and Epidemiology Officer and all things ID. He's going to talk about vaccine, all the concern about variants, and some updates regarding quarantine, etc. from the CDC. Dr. Lori Rubin, the Chief of Infectious Disease at Cohen's Children's Hospital, who's going to give us an update of COVID-19 in children and all things that we come to expect in the coming months and all the concern about kids. And then we've got a couple more community updates from Staten Island. Dr. Ted Maniatis, a pulmonary critical care physician and the Chief Medical Officer at Staten Island, is going to tell us what's been going on at Staten Island and a bit of a thank you to everybody there for all what they have done over the past year and a half. And Dr. Sahel Shah, an internist at North Shore University Hospital and former leader of the Staff Society and a number of other key roles, who's going to also talk about the year of COVID and a community physician perspective from North Shore University Hospital. We'll finish up with a panel discussion and a book. And without further ado, Bruce, so much going on. Tell us about it.
Thank you, David. Next slide. So 2 weeks ago, we had an update, and I told you that we were very confused because the policy of the CDC in New York State were opposite one another and left many of our clinicians totally confused. I'm happy to report some really good news. They have been clarified, and I will summarize them briefly on this slide, which states that if you have been fully vaccinated, that you can travel domestically, come back to North Shore Hospital, work, and do not need any tests at all. That changed literally 1 week ago today. If you travel internationally, again, depending upon whether you've been fully vaccinated or not fully vaccinated, you see the changes. If you've been fully vaccinated, you can come back and get tested on 1 to 3 days before traveling outside of the United States, meaning before you leave. And then you have to self-quarantine for 7 days with a negative test or 10 days without a negative test. So, and it's even more onerous, as you can see, if you're not vaccinated. So domestic travel is a free-for-all now, go wherever you want. International travel is still problematic. For domestic travel, you do not need to get tested or self-quarantined if you have recovered from COVID in the past 3 months. Next slide. Regarding other exposures, asymptomatic individuals who have been fully vaccinated against COVID do not need to quarantine after exposure to COVID, a new change that has finally been clarified. For individuals exposed to COVID who are not fully vaccinated or who have not recovered from COVID in the previous 3 months, a required quarantine of 10 days is needed. Testing is not required to end the quarantine if no symptoms have been reported during the quarantine period. And healthcare workers, interestingly enough, working in a nursing home or an assisted living must furlough for a full 14 days. This is quite an amazing number. For previously exposed individuals who are asymptomatic, you are not required to retest or quarantine, providing the new exposure is within 3 months after the date of onset of your first COVID infection. Next slide. Now, regarding COVID, I want to make the point that we've been making actually for the last couple of weeks, that COVID is not over. 23% of Nassau residents have been fully vaccinated, a little less in Suffolk, close to 18%, and in New York County, it's 22.4%. We're getting there, but that's still a minority of the population. Immunosuppressed patients, we still do not have good data other than that they lose their antibodies much quicker than non-immunosuppressed patients. Background community rates have not fallen and are higher than compared to last summer when we were really very low. And hospitalization rates are much lower but have plateaued over the last 3.5 weeks. Next slide, please. So let me get into these variants that David was mentioning. The CDC has now classified variants of interest versus variants of concern. In my own personal view, I don't think there's a lot of difference between a variant of interest and a variant of concern. All of these have reduced efficacy to the monoclonal antibodies. The single-dose Lilly product has now been removed from the market, and there is good data to demonstrate that the combination of Regeneron is better than the combination of the Lilly products in terms of inhibition with many of these variants, as we will talk about. They all are associated with an increased risk of transmissibility and or disease severity. I'll go through a little bit more detail regarding those. Regarding the linkages, we're most interested in the B526, that's the New York variant. The B525 is another New York variant, but is not nearly as important. And the other ones I'm going to go through, but are listed on the right-hand side, that have all been associated with either a 20 or 50% increased risk of transmission. That is the problem that we're facing. Next slide. So what do the numbers look like? This is a nice replica of how quickly these variants can take over a community. This is in California, and you can see the B117 has dramatically increased the percent each week that it has been followed. And that is happening virtually all over the United States, although these data came from California. Next slide. Now, regarding the proportion of variants in each state, they also vary considerably from state to state. The US is not one common area when it comes to variants. Let me give you a couple of quick examples. In Florida, 13% of the variants are the B117, and you can see that the South African variant 351 is quite uncommon across the United States, but not non-existent. In New Jersey, B117 accounts for 9.4% of strains, but in New York, only 3.7% of strains. Next slide, please. So let's look at New York. This data is up to date as of 3/23/21. If you're interested, this data is posted weekly on the New York City Health Department's website. And I like it, I follow it. But if you notice, look at the last 5 weeks of the percent. B117 is slowly growing. It varies from week to week, but you can see it's between 10 and 17% in New York. Up, but not nearly as high as predicted by the models that said that it would be the overwhelming predominant strain by the end of March. That has not come to fruition as predicted. But on the other hand, look across the slide that's circled is the B526 variant, divided into 484 positive and 484 negative strains. So this 526 in totality accounts for 32% of all strains in New York now. And about half of them carry that horrible gene or mutation, the 484. That's the mutation responsible for increased transmissibility, increased resistance to monoclonals, and in certain circumstances, particularly with the AstraZeneca vaccine, it decreases the effectiveness. With the other vaccines, they seem to be holding up in preventing severe disease and hospitalizations. They may be less effective in preventing all cases, symptomatic and asymptomatic, but they are still very good in preventing severe disease. You can see on the bottom part of this slide, in New York, there were 1,800 526s compared to 590 B117s in the week ending 3/23. Next slide. So what else did we learn this past 2 weeks? We learned that the 2-dose Moderna vaccine and Pfizer vaccines both prevent 90% of infections by 2 weeks. This is a reiteration of what we knew, but it's a new study. The 1 dose prevents 80% of infections by 2 weeks after vaccine. Excellent results. And we also know that in a study, the CDC enrolled 3,950 people at high risk of exposure because they were healthcare workers, first responders. None had previously been infected with the coronavirus. And you can see the dramatic response of these 2 vaccines in healthcare workers. There were 0.19 infections per 1,000 patient care days among those who had received 1 dose of the vaccine. In contrast, there was 1.38 infections per 1,000 patient care days in unvaccinated people. Really quite dramatic. Next slide. So let me just give you another piece of information. My only disappointment is that we really are seeing vaccine hesitancy. 62% of the staff of North Shore University Hospital, Northwell Health System, has been vaccinated by the last day in March. This doesn't include April's data, but it's 62%. We would obviously like to have that higher, and everybody has been given an opportunity to get this vaccine who works for Northwell, so there's no reason that they can't get it. Next slide. So regarding what Northwell has been doing recently, 1,500 chronically ill, frail, homebound people have been vaccinated. This will continue and increase the volumes. That's a very large number. As you heard the mayor of New York City saying that they were doing 200 per day in the entire New York City Health Department. So we're doing pretty well compared to them. We now offer COVID vaccines to all our families of all our staff members and all team members. That's something that people have wanted for many weeks. We now have enough vaccine to offer that. And we are offering Johnson & Johnson to all eligible people at the time of discharge from the hospital. That's been a success. The numbers are good, not amazing, but roughly 100 per day are being vaccinated. We'd like to get that up higher as the eligibility has opened up. Next slide. Regarding the breakdown in New York, and this is sort of the disappointment, Asian and whites have been vaccinated a higher percent than Latinos and blacks, and Bronx and Brooklyn have lower rates of vaccination than Manhattan. 20% of Manhattan adults have been fully vaccinated compared to 12% in Brooklyn. We need to work on these underserved communities. To me, that's probably the most important thing we can do to getting the epidemic under better control. So we need to work on these, this situation, I think, and give more resources to underserved communities. Next slide. Regarding New York, you can see basically what I've said in a map distribution. You see the light green areas are those where the penetration has been under 25%. And that's mostly in the Bronx and parts of Brooklyn. You can see the high penetration of dark green where the rate of penetration is over 50% in the higher economic areas of Manhattan. And the rest, it's scattered. And you can see Long Beach, which has a great take of vaccine. Next slide. Reinfection rates, just a couple of more slides on reinfection rates. You see this study that came out that I think was very good, that looked at a very large population of over 600,000 tests that were collected from 386,000 individuals from health systems throughout Ohio and Florida. An initial infection status was based on tests performed prior to vaccination in August, prior to August 30th of 2020. So this is nothing to do with vaccination. This is looking at what is your rate of getting reinfected if you've previously had COVID. How good is COVID in giving you long-lasting immunity? And for patients who tested positive, they considered any test greater than 90 days after the initial infection to be a reinfection. I realize that there's problems with that definition, but when you're looking at 400,000 people, it gives you a pretty good rough idea. And they looked at infection rates at 4 to 5 months, at 6 to 7 months, and greater than 8 months following the initial test. Next slide. What you can see is that reinfections are occurring. They're occurring starting at about day 100. They're not at huge numbers, but what this study demonstrates is that COVID does not give you permanent immunity from getting reinfected. Another reason why people need to get vaccinated even if they've had COVID. Of 62 reinfections that were seen, 31 were symptomatic. 18 symptomatic patients were hospitalized within 30 days of a positive test. 5 patients had symptoms possibly related to COVID. However, none of the patients required ICU care. So people are getting COVID again. They rarely are, they're not hospitalized commonly, and when they are hospitalized, they're rarely critically ill. But many reinfections are going close to the 90-day initial infection. I will tell you that's not on this slide that Moderna announced this week in a letter to the editor of the New England Journal that their vaccine has very good neutralizing antibody at 6 months. And I think that that will pave the way in the not that distant future for the CDC in New York State to extend that 3-month mark, which many of you on this call have passed already, including myself, to 6 months, because basically all that guidance kind of goes out of the window if you read it at 3 months. Next slide. To end, 6 months consequences of having COVID are still a big problem. There's a lot of questions about what to do with these people. Many places in the city and other areas have set up clinics as well as our health system. And quite frankly, no one really knows what to do with these patients. This is a brief summary of a large group of people that were studied in China. Next slide. What it demonstrates, and these are problematic studies, this was a questionnaire, but it demonstrates that they were common in people who are hospitalized and also common in people who are not hospitalized and were relatively young and had uncomplicated COVID. Hypertension, diabetes, cardiovascular disease were common, but 68% of the participants in this particular trial required oxygen, unlike many other studies that show that this happens to young people who never had oxygen requirements. 76% of people reported one symptom that was at least 6 months old. The most common after discharge were fatigue, muscle weakness, sleep disturbances. 23% of the people reported anxiety or depression, and some people had serious mental problems that had never occurred prior to COVID. No history of prior psychiatric illness. Next slide. I will turn it over to you, David. Thank you for the time.
Thank you, Bruce. And we'll obviously have some questions for you, and we'll be regrouping at the panel discussion. So Dr. Lori Rubin from Cohen's Children's and leading the Pediatric Infectious Disease Division. Lori, this has been a long haul for you as well. We haven't heard much recently as we're looking forward to really getting children vaccinated at some point. So we'd love you to comment on what you think is going to happen there, as well as what are we seeing in kids now, because it does seem like this is sort of making its way into the younger group yet again. Lori?
When we're talking about COVID-19 in children, we're really talking about two diseases. There's the acute COVID-19, and it's true that in children, asymptomatic infection is common, and overall it's much less common and much less severe than in adults. However, severe infection and deaths do occur, and that severity generally increases with patient's age. So adolescents with COVID-19 look a little bit more like adults than do younger school age and infants. And the second disease is what's referred to as MIS-C, which stands for multi-system inflammatory syndrome in children, that I'll go into in more depth. This occurs 3 to 4 weeks after the SARS-CoV-2 infection. All of these patients are hospitalized and almost 2/3 require ICU care. Next slide, please. So in terms of the impact of COVID-19 in children, I think it's more relevant to think of it on its own rather than comparing it to adults. And if we look at other vaccine preventable infections, such as varicella or rotavirus that I have circled, and we look at the number of deaths per year in the pre-vaccine era, you can see there's around 50 children per year. Through the end of through December of 2000, there was 185 deaths in children in the United States. So the impact of COVID-19 is as important or more important than other vaccine preventable infections. Next slide, please. So I'm just going to go through a few aspects of SARS-CoV-2 infection in pediatric patients and then talk some about MIS-C. And I think we're all very concerned when we saw women coming in labor that were either symptomatic or asymptomatic, but were PCR positive. We were concerned what the impact on the infant, the newborn, would be. And indeed, the impact is surprisingly benign. So that perinatal transmission is uncommon, congenital infection is quite rare. And just from 2 series, there's a national registry that found that if you take women that are SARS-CoV-2 positive when they come in to deliver and test their infants at 24 to 96 hours of life, they found 1 to 3% were positive. A series from Northwell using 5 delivery hospitals of 466 patients, we found no positive children when tested at 4 to 6 months of age. And another study by Sophie Jan found that of 85 infants, of these infants who were born to COVID positive mothers, tested negative at 24, 48 hours of age, only 2 were positive when tested 4 to 14 days of age. And some of these may have been acquired in the household. And when we do get these infections, they're generally asymptomatic. Next slide, please. And then another experience we had in the spring of 2020 is we looked at our febrile infants 2 to 8 weeks of age. And as you may know, if a 4-week-old develops fever at home, that's a ticket into the emergency room for a evaluation for serious bacterial infection and an admission to the hospital for antibiotics pending the outcome of that test. And we found that COVID-19 was the most common cause of fever in these admitted hospitalized infants. That was the bad news. The good news was that the disease was mild. Basically, the median hospital day was only 2.2 days. 2.2 days. Although they had poor feeding and lethargy as some of their symptoms, respiratory symptoms were infrequent and mild, and none of these had serious bacterial infection. Next slide, please. So this is our epidemic curve of children hospitalized at Cone Children's with SARS-CoV-2 infection from March of 2020 to the present time. And I just circled 2 areas to indicate sort of March into April of 2020 when we had our initial phase, and then in November when we started the second phase that, as you can see, continues to occur. I'll contrast that with the next slide, please. And this is our MISC cases that I want to talk to as well. So if you remember from the previous slide, and you look at the peak of these cases, that it's occurring about a month or so after the acute COVID cases. And again, we're still seeing those cases into February and March occurring, kind of tracking nicely a month or so after the acute COVID cases. Next slide, please. And the CDC definition is fairly broad, but it's a child under 21 years of age with fever, laboratory evidence of inflammation, 2 or more organ system involvements, no alternative diagnosis, and a positive COVID test or exposure. In practice, this results in COVID serology being positive in nearly all patients, given that it's a post-infectious syndrome. There are a subgroup that also are PCR positive, not surprisingly, since we know that after acute infection, the PCR positivity can last for 90 days or more. Next slide, please. And the median age of cases is 9 years, and you can see that it really spreads throughout the pediatric age group. And I'll show you the different syndromes in different age groups, essentially. Next slide, please. So of the over 3,000 cases that reported through the state health departments to CDC, there were 36 deaths, a little over 1% case fatality rate. There's a male predominance, and also overrepresented are patients of Hispanic ethnicity and Black race. And the attack rate, that is to say, I should mention that the majority of cases of MISC that we see in the hospital never had a recognized episode of acute COVID. So they may have had COVID in the household, was very common. So it's not the case that you need symptomatic COVID to present with MISC. But looking at the rates during a period of time of the 2 syndromes, that is PCR positivity in the pediatric age group and MISC cases, the ratio is about 1 to 650. So it's very, very rough. But somewhere 1 in 500, 1 in 1,000 SARS-CoV-2 infections appear to result in MISC. Next slide, please. And so all of these patients have fever and all gastrointestinal symptoms such as vomiting, abdominal pain, diarrhea. There's a number of patients that actually have colitis documented on imaging. And as I mentioned, all patients, virtually all patients are seropositive for COVID. However, the presentations vary. The most important presentation occurs in a little bit in the older age groups. So this is the 8, 10, 12 and older groups primarily present with shock. Require ICU care. On imaging, they have impaired ejection fractions. They oftentimes require vasoactive medications, and obviously in the intensive care unit. And these have the highest CRP levels, so it's not unusual to see a level of 300, 400 milligrams per liter. The other presentation, number 3 there, is a Kawasaki-like presentation. So we've recognized Kawasaki for decades as an illness of young children with a median age about 2 years that have fever, rash, conjunctival injection, oral inflammation, an enlarged lymph node, and extremity changes such as swelling of the hands and feet. This is a presentation that COVID has in the younger age groups, and sometimes it's really indistinguishable from Kawasaki. They tend to less commonly require RCU care. And then there's a third group that may be more like the adults that get acute COVID and then go into the hyperinflammatory syndrome. And these again are overrepresented more in the adolescent group. Next slide, please. And to talk about the COVID-19 vaccine trials in children, so as everyone knows, there's 3 vaccines licensed in the United States. And each of these 3 vaccines, as well as some vaccines that are likely to be licensed, have ongoing studies in children. I present the data here because this was the first data that's available in a press release from the Pfizer mRNA vaccine. And this is very similar to the other vaccines because again, these studies were designed with the FDA and discussed with FDA. So the studies will work their way down the age group. In the case of the Pfizer vaccine that's licensed for 16 and older, it's studied in 12 to 15-year-olds. And about 2,000 children were randomized to get either the vaccine or a placebo injection. They did follow for COVID-19 infections, and indeed, this was very effective in this study with 18 cases in the placebo injection group and 0 in the vaccine group, and looked at neutralizing antibody titers were very robust in this age group. In fact, they were higher than in the 16 to 25-year-old age group in which high efficacy was noted. And then that will sequentially then work their way down the age group. In the sort of 12 to 15 or 12 to 17 for the other age groups, they would be likely using the same dose of vaccine as in adults. In the younger age groups, there will be preliminary studies to do sort of a dose finding to see if 1/2 the dose, 1/4 the dose is the appropriate dose rather than the full dose. Although we have many precedents for other vaccines where young children and adults receive the same dose of vaccine. This will sequentially go from 5 to 11 age group, 2 to 5 age group, and then the 6-month to 2-year age group. So that's pretty advanced in Pfizer, also have been in place for quite a time in the Moderna vaccine. And so we'll wait to get those. Of course, these results will then need to be submitted to FDA, which will have to evaluate them, go through the FDA advisory panel before an EUA might be issued for a vaccine, which will clearly first be in the adolescent age group, the 12 and above.
Great, thanks, Lori. So it's encouraging to see that the studies are moving forward, and we'll talk a little bit later about when you think we may have some information about when we can, in fact, launch in these other groups. Okay, shifting to Staten Island, Dr. Meniatis, tell us about what's happened out that way, and we just want to echo our thanks to everyone involved, in particular our community physicians.
Thank you, Dr. Bettinelli, and thank you for letting me deliver this presentation on behalf of the community physicians working on Staten Island. They really appreciate it. I will express some of their perspectives in the form of questions and the actions that they've taken during 2020. This first slide is purposely pretty complex because I wanted to demonstrate how complex community care medicine is on Staten Island. Community docs provide care through UPG services, University Physicians Group, which is sort of a subdivision of Northwell Physician Partners. There are also quite a few voluntary physicians on Staten Island, people in completely private practice. And we also have physicians taking care of Staten Islanders who are employed by other health systems, mostly New York health systems. Next slide, please. During COVID, especially early COVID, we created a lot of what we call, what I call pop-up critical care units. The unit in this slide is our ED3 unit. which originally was designed to take care of patients waiting to move into the hospital after admission, who had to wait for a little while. This was one of the first places or locations we created a pop-up critical care unit. And during the first part of the pandemic surge in March, we were just overwhelmed. There weren't enough expert physicians to take care of all the patients we had. So our pulmonary outpatient docs actually reached out to us. I define these people as people that were trained in pulmonary or critical care medicine, but had decided for the last several years to practice mostly outpatient medicine. They volunteered to work in the hospital, and if they were experienced enough, we actually let them run one or two of these units, and if not, they acted as a middle person, a person taking care of the patient, but being supervised by someone with more current experience. We also got calls and offers from just about every type of physician in the community, including psychiatrists, gastroenterologists, endocrinologists, rheumatologists, and they helped function as everything from runners to mostly communicators. These docs would round with the teams in the hospital, and at the end of the rounds, get on the phone and update the families, and a lot of times update other providers who wanted to keep track of what was happening with their patients in the hospital, since access was limited. And this was extremely helpful. Next slide, please. They also wanted to help take care of patients outside of critical care units. The building you see in your upper left is a brand new, beautiful, state-of-the-art, state-owned psychiatric facility, which has yet to take care of a psychiatric patient. The picture on the lower right is a wing of that building with a hallway and some patient rooms off to the sides. Not really set up exactly for taking care of acutely ill hospitalized patients, but we made do with it. And through an arrangement with New York State, we took control of that building during the first pandemic, since the first surge, or at the time of the first surge. And we reached out to some physicians, but got calls from a lot of other physicians in the community. We staffed this building with hospitalists, UPG primary care physicians, many of whom had not taken care of an inpatient for quite some time, and a bunch of voluntary primary care physicians who called us and offered to work in these facilities. Some of these docs traveled in from Brooklyn, some of them traveled in from New Jersey daily to help staff this building. And by the way, this was before the COVID extra pay program that was initiated. We also needed a way to get these patients discharged from this facility efficiently back into the community. At times, we had as few as 6, and at the peak, as many as 65 patients in this facility. I called up Dr. Brown, and within 24 hours, she had her COVID-19 follow-up program set up at this facility, and interacted beautifully with the people in the facility and the primary care physicians who would pick up the care in the community. Next slide, please. The community docs had quite a bit of concern about interaction with our Go Health urgent care centers, both referring patients there usually for testing and when they were acutely ill, and then taking care of patients who left those facilities with recommendations. We kept the docs updated by sending them routine updates of the medicine service line COVID-19 ambulatory clinical protocols. When they started to have some concerns about practicing different ways, and if you remember way back when, there were a lot of questions about hydroxychloroquine, vitamin C, famotidine, colchicine, and various other treatments. We solved all those small problems between the community docs, and some excellent communication with the leadership of the Go Health organization and the help of Dr. Salvador. So there's a very nice working relationship between our community care physicians and our Go Health urgent care centers. Next slide, please. They had and still have questions, including how do we refer patients for infusion therapy, when will office vaccinations be available, and where can vaccinations be obtained. The clinical call center was a phenomenal success. After about the first 3 or 4 days where we ironed out some issues, the community docs began making routine referrals for monoclonal antibody treatment using the clinical call center. They're very, very active in getting patients infusions when they meet the guidelines. And as far as vaccinations and what's going to happen in the future, they've been updated with the recent presentation. I think it was last week or 2 weeks ago by Joe Lamantia. Next slide, please. These docs, especially the ones that weren't employed, or only the ones that were employed, had some serious financial concerns during this. I know many of these people for half a lifetime and have spoken to many of them. Amazingly, they all made it through by expanding their use of the telehealth modifications and providing telehealth services, which was a benefit to them and the patients. They all took advantage of the Paycheck Protection Program loans. They all took advantage of the Health and Human Services payments that were created as part of the CARES Act Provider Relief Fund. And as you can imagine, many of them are now in negotiations with Northwell and other health systems. As you can imagine, some of them want now to give up voluntary practice and become employed physicians. We have an opportunity here to get them to join with Northwell and not other facilities, not other health systems. And I honestly believe that the beautiful relationship that we had during 2020 with our community physicians and Staten Island University Hospital and Northwell is about the best advertisement we could have made for them to sign up with Northwell if they're going to sign up with anybody. Next slide, please. They all ask, what does the future look like? I honestly don't know what the future looks like, but I assure them of 3 things. COVID's here to stay. We'll always see some COVID. Telehealth is here to stay. Telehealth will grow. And if the pre-COVID movement of healthcare is like that crowded Bell Parkway on a Sunday afternoon, the post-COVID movement in healthcare is more like that speed zone free Autobahn picture on the right side. I think I'll stop there.
Hey, thanks very much, Ted, and thanks to everyone on Staten Island and the community. Make sure everybody understands how much we appreciate all of their hard work, and I think we'll talk a little bit more about that on the panel, so thank you. Dr. Shah, tell us about North Shore University Hospital and the community physician perspective, and again, a big thanks to the Staff Society and everything that everybody has done to help everyone through this period of time and it still remains.
Thank you, David. Thank you, David. Thank you so much for giving me the opportunity to talk to you and others about what happened during the year. As we know, the beginning, when nobody knew anything, it was just whisperings from across the world. We knew it was going to happen. It did. And in March, we saw our cases come. Everybody was totally unprepared. None of us knew what it entailed. None of us knew what was going to happen. We're all operating in a fog of ignorance. I mean, it's just inevitable when something new like that happens. And initially, the huge impact was most physician practices, most individual private physician practices, and even Northwell practices, faculty practice, they shut down. Nobody had any idea of how to deal with the crisis. The hospitalist initiative in the hospital, we were actually hesitant for about a day, and then when we realized how important it was to contribute, I think it was gone. That same exact, the same impetus that the hospital Northwell system took to ramp up the whole presence of hospitals in the hospital will be actually very, very useful to everybody. So we all volunteered. Next slide, please. The ground reality for all physicians changed. It was like the most common fear was getting COVID, and then what would happen to everybody, what would happen to our families. I asked around I asked around with private physician practices, and asked them what their main fear was, and they said the utter feeling of loneliness. It was like almost like there was nobody out there to help. They had to compete in the real world for essentials like PPE. You couldn't even get a sanitizer off Amazon. If you paid like $50 for a small bottle, you couldn't get it. So forget about commercial grade sanitizers. So these were some common fears out there. And physician organizations, I won't name any, but they really struggling on their own. They did not know nobody knew what to do. So there was basically no help for individual physicians or individual practice. The Long Island physicians community physicians are a diverse bunch. A lot of them are affiliated with big systems like Northwell and NYU, but a lot of them are on their own. So they're a diverse bunch, and it's hard to basically communicate uniformly with everyone. Next slide, please. As April, May, June came in, and some of the private practices tried to get their practices to run again, the most important thing they found was the reluctance of their employees. Employees did not want to come back to work. There was a whole host of obstacles that were in place for their practices to start. The ramping of telemedicine in private individual practices was slow. It was communication issues, it was connection issues, it was employee hesitancy. Very few community physician practices were able to ramp up adequately to actually make sure that they get some revenue. Of course, the loans and the government help helped, but it was far too little to actually impact the revenues immediately. The voluntary hospitalists jumped into the fray, as I said, after initial hesitancy of maybe less than a day, and we jumped into the pool, so to speak. We were asked by the Department of Medicine, and we volunteered. I think at the peak, we probably took care about 40% patients, and most of them were at that time, at the peak, were COVID-19 patients. The biggest help in Northwell Health, the biggest huge help was we had absolutely no dearth of PPE. And that was a huge factor that made us very, very comfortable. We had no hesitancy. We had no lack of gloves, no lack of gowns. In fact, many times we felt bad that we were using a lot of this PPE, but we were advised to, and Dr. Farber and Dr. Hirschberg were on our back, make sure we adequately protect ourselves. COVID-19 updates that we had from Bruce, especially you, Dr. Farber and Dr. Hirschberg, they were very regular. They were almost weekly initially, and they were incredibly helpful for us to be guided as to what medications that we had, what limited arsenal of medications we had to use against COVID. But thank you for that. Next paragraph, please. Next slide, please. The rise and subsequent fall in hospitalizations, obviously, we already know. Bruce has spoken to that on multiple occasions. Currently, we're at somewhat of a plateau, as Bruce said. I myself haven't had any particular COVID hospitalizations in the last 2 or 3 days, which is actually a change. Sadly, we lost a lot of esteemed colleagues in the physician community, both outpatient and inpatient. We lost a few. It was, I guess, an inevitable part of a global pandemic. Most private practices by now have started to function on almost like a common, almost like a pre-COVID timing, but however, it's not quite the same. A lot of them still do they're still practicing telemedicine. In fact, my daughter has allergies, and she routinely has to go online and do telemedicine with her doctor for her allergies, and she has not gone to her office in over a year. We're grateful to Northwell Health's vaccine rollout. It was incredibly helpful to all of us, and we in the hospital setting, especially being exposed on a daily basis, almost like swimming in COVID, so to speak. So we're thankful to Northwell Health's vaccine rollout, and I got mine at the end of the year last year, and that was hugely helpful. All the community physicians affiliated with Northwell have been offered, and I'm 100% sure that most of them have received the vaccine from Northwell Health. Next slide. The future is continuing frustration. We still don't have definitive treatment for COVID. We have some effective agents, but not enough for us in the hospital setting, especially to feel that, okay, yes, I'm definitely treating this UTI with ceftriaxone. It's not the same thing, but we definitely have seen improvement in outcomes. Dr. Farber just addressed the uncertainties regarding the duration of immunity, and I think those will stay with us until a couple of years have passed. We don't know how long people will be immune. However, optimism has started to return. People have started in whisperings in the medical staff lounge as to going on vacation, and when we're planning this and planning that for the year March 2020 till I guess December 2020. Nobody spoke anything about travel. There was high stress and burnout in that year, especially among hospital physicians, because they were exposed to constant barrage of patients, and obviously the continuing stressor of the need to maintain ceaseless vigilance. Next slide, please. There are countless articles on the crushing effects of COVID on medical practices, and there are huge numbers of articles on various newspapers how doctors are under stress. Some of them are quit, never to come back. Just takes a simple Google search to find more. I just listed a few of the most striking examples. Next slide. So we're thankful to everybody. This is the group of voluntary physicians who were instrumental in fighting against COVID in Northwell Health in 2 hospitals, North Shore LIJ and North Shore, Manhasset, and LIJ Medical Center, and some of them actually go to Forest Hills as well. We thank you, Northwell. Thank you, David, for everything that you did. And I guess I'll stop there.
And thank you, Sahel and Ted, for taking the time and helping us better understand everything that went on. And obviously, a huge thanks to you and everybody who supported you. So let's transition to our panel discussion. We've got a few questions. Maybe we'll go back and forth. We're going to start with you, Bruce. So you hear so much about the variants, and I think to your points that some of the more serious variants that we really worried about getting into the area sort of haven't gotten here. We've got our New York variants, et cetera, and we've got this race to get people vaccinated. But we've also gotten, it's all over the news today, big concern about, despite the CDC recommendations, despite President Biden's urgings, we can't seem to control the various local politicians, governors of the states, and it just it's worrisome, right? That you really could use another 2 or 3 months of vigilance before you sort of get to that point. Do you feel, and I've talked about this before, that yeah, the variants are important and the transmissibility is an issue, but the public health measures have proven that they can hold the fort while we get the vaccine out, if we can only get that message to penetrate?
Yeah, make no mistake, the variants are worrisome and need to be followed, but in reality, nobody is getting serious COVID now who's been vaccinated. And the variants have, from a practical point of view, are something to be concerned with down the line. But right now, still only 25% of our population has been vaccinated in New York. It's growing every day, but you're 100% right. If we could just stop and just, stop being crazy, literally, about, the social distancing and the masking. I mean, that bar episode that I would love to present at a future date caused a huge, one episode in a bar caused a huge community outbreak in a town in Illinois. So I agree. And unfortunately, the reluctance of vaccines is also the thing that scares me the most.
As you know, we're sort of teetering with our admissions at the hospital, hovering around 700, sort of flattening and plateauing to some extent. Hopefully that continues to move down as we race with the vaccines. I'm a little pessimistic that we're going to change the minds of the people, because it just seems to be the mindset is, we're sort of through it. Lori, trying to get more comfortable with vaccines in children. Are you seeing a lot of resistance to, in conversations with parents, or are people anxious to get their kids vaccinated?
Yeah, I'm sure that the parents are fall into two groups. The ones that I've had the most conversations with are the ones that just can't wait to have the vaccination so that their kids can have the confidence and decrease their own anxiety about getting COVID, as well as ideally return to more of their normal life. So I'm seeing a lot of enthusiasm. It would be no surprise that the adults that are somewhat reluctant to get a vaccine may also be more reluctant to have their children receive the vaccine, of course. So we have work to do in terms of that hesitancy, which has been in the pediatric vaccine world for a long time.
Yeah, my understanding, reading in some other previous books and things, is that even with the MMR, for example, there's a problem getting the second dose for a lot of people who don't want to return on schedule.
Right, and there's, the good news is in terms of parents that are hesitant, there's a large population, a large proportion of that are kind of on the fence, just need more education and can be convinced about vaccination. There's a very small percentage which you might as well just save your breath about that.
Bruce, anything more we should be talking about with respect to reinfections? And what do you think the actual schedule is going to be in the coming years with respect to mass vaccination?
Well, the Moderna vaccine variant trials have started already, and I think that the CDC will probably change to 6 months. And based on the levels that are initially being reported at 6 months, I think we have a very good shot at a year. I don't think anyone really knows what happens after a year, and whether we're going to be going through this every year or every 2 years. I don't think it's going to be lifetime, that's for sure.
Yeah, I mean, the big concern, again, trying to get the message to the public is, we hear this race also towards herd immunity, and with this idea that once we reach herd immunity, we don't ever have to do anything again. And obviously it will be only if herd immunity persists.
At the current rate of vaccine hesitancy, there is no realistic rate we're going to get there in that scenario. I mean, look at the MMR and measles. We're at 97% to get there. More than 3 or 4% screws the whole immunity in MMR, if I'm right, Lori.
Yeah, no, concerning. Ted, it's great news to hear that same message, I think, that Sahel has put forward, that what we've been able to do, despite how overwhelming it was to help support our communities, community physicians, and forge stronger relationships, which is key. I would assume a lot of people would like to be employed. Some people don't want to be employed. I think ideally, from my perspective, you'd like to be able to support whatever the practitioner feels most comfortable with. But certainly, I think the comfort level I'd like to see is that people understand that during times of crisis, our community physicians will be supported, even if they're not employed. And that is what builds a stronger community. I'd love to hear the perspective from you two.
I agree completely with what you said. And that was especially demonstrated with the physicians who actually take care of patients on Staten Island, but are employed by Mount Sinai and NYU. They were treated no differently than the physicians in the community who were employed by Northwell, who are voluntary.
Sahel, how about you?
I would echo that. I think the instrumental fact that came out of this whole year was how strongly Northwell Health supported the community physician in everything that they did. Yes, the vaccine rollout went to the physicians most at risk, but then when everybody got the vaccine, everybody got on the schedule, and I think the information flowing out of the Department of Medicine through various avenues, especially from Bruce, we're very thankful to that, and Dr. Hirschberg is chair of the Department of Medicine. So I think we are all extremely grateful. And I think the community physicians appreciate that. I mean, they're a diverse and sometimes fractious group, but I think when it comes to this, there was no sense of panic, and that was incredibly encouraging for us, because the capacity was increased so much, and it was done no sense of panic. It was very, very reassuring, and I think community physicians know that. They appreciate it.
Well, that's great. Again, we appreciate the perspectives and the strength of the communities, and obviously diversity is what keeps us all strong. So thanks again. All right, I'm going to transition to this week's book. Again, one of my favorite authors I've talked about before, Adam Grant, the youngest full tenured professor at the University of Pennsylvania, Wharton School of Business, a social psychologist. He's written other books I think that you're familiar with. Next slide. Give and Take is one that we talked about previously, one of my favorites. The Originals was recent, and this Think Again is actually written within the last year. He's also done a bunch of TED Talks that encourage you to sort of listen to him. Next slide. And we've just talked about that. Next slide. And he's gotten a lot of press. And, you know, sort of the main message is to take the time to think again. Why an open mind is essential even during divisive times. And I think we've obviously been immersed in critical times and sometimes divisive. Getting to some of the points that Dr. Shah and Dr. Maniatis made was, it was a scary time, it was a fearful time, it was an overwhelming time. On the other hand, I've heard from so many practitioners that it was perhaps the most rewarding and most transformative event in their professional lives. So, you know, with the stress of all this kinds of stuff, there is an upside. Next slide. So this is all about really, you know, being open to what we don't know. And so this little sort of Venn diagram or pseudo Venn diagram is, you know, a little circle about what you know, and eventually that big circle, of course, of what you don't know, and being as a leader in particular, critical to understand that you need to listen, you need to think again. Next slide. And perhaps most important is being able to set up an environment of psychological safety. So, because when you have it, there are certain characteristics, and when you don't have psychological safety, there's certain things that happen. So just a couple of examples. So when you're safe, you see mistakes as opportunities to learn. When you don't feel safe, you see them as actual threats to your career. When you have it, you openly share your struggles. When you don't feel safe, you know, you only talk about your strengths and you keep everything else to yourself. You know, the big example of, you know, when you feel safe, you know, you're okay sticking your neck out. And when you don't feel safe, you're worried about having it chopped off. And if you really want to listen and hear everything that's of concern to people, you need to create that psychological safety. And one of the things I think that we tried hard to do during this event was keep people safe, and not just psychologically, but also be willing to hear their struggles. So, you know, when we didn't have enough PPE early on, when people were fearful, it was understandable. Next slide. And then I had to put this one in here because not so much because of the quote, although the quote says a captivating argument that great thinkers and achievers don't let expertise of experience stand in the way of being perpetual students. It's a great quote, but more than that, I mean, my favorite movie, The Sixth Sense. Split's a crazy movie, not one of my favorites, but M. Night Shyamalan is a genius. Next slide. So let me leave you with that. This is a great read. Really opens your mind to how you can actually pull this off in real time. Next slide. Again, Think Again by Adam Grant. Next, Once again, thanks to all our panelists. Thanks for everybody participating. Please send us your feedback. We need to know what to focus on. Next slide. And most important, thanks to everybody behind the scenes who makes this possible for all of us to continue. With that, be well, be safe, and you'll hear from us again in 2 weeks. Spread the message.